It's a great pleasure to introduce Dr. Ellie Ragsdale today. Dr. Ragsdale comes to us from Cleveland, Ohio. She's an assistant professor in the Department of Reproductive Biology at University Hospital's Case Medical Center at Case Western. She actually joined the faculty when I was the chief resident there. So we go a long way. It is such a joy now to see her that she's now the director of fetal intervention at the Congenital Cardiac Collaborative that was established there. Dr. Ragsdale completed her medical school from Wake Forest in North Carolina and went on to then complete her OBGYN residency from Weill Cornell in New York, and then pursued her subspecialization in maternal fetal medicine from Albert Einstein Montefiore Medical Center. Dr. Ragsdale was actually a key member of the team that performed the first successful fetal cardiac intervention in the state of Ohio. If I remember correctly from the news, it was a case of critical aortic stenosis. And maybe Dr. Ragsdale will mention that case in her presentation today. She will be sharing her insights on fetal cardiac intervention, primarily in single ventricle lesions and its impact on the field. A very warm welcome, Ellie, from all of us here at Rutgers.
Thanks for sharing. It's good to see you. Thank you guys so much for having me. So I have a lot of slides. I'm going to try to get through as much as I can. I have a lot of videos and images, so please let me know if they're not playing as we go through, and I can try again to share this slide so you guys can see all the videos later on. So the title of this talk is Fetal Cardiac Intervention, Altering the Course for Some Single Ventricle Lesions. As Rashira said, I'm Ellie Ragsdale, the Director of Fetal Intervention at University Hospital's Rainbow Children's Hospital. So I don't have any disclosures. At the conclusion of this talk, my hope is that everyone who hears this can describe the risks and benefits of fetal cardiac intervention, list the markers for evolving hypoplastic left heart syndrome, and describe the pathophysiology of an intact atrial septum in the setting of congenital heart disease. Hopefully, everyone at the conclusion of this talk will be able to appropriately identify a good candidate for fetal intervention, and taking it even a step further, just a good candidate to be evaluated at a fetal center for cardiac intervention. So what is the big deal? Why do we think about this so much? Why is congenital heart disease such sort of a hot topic of research and development in fetal therapy? Congenital heart defects are the most common birth defect that we identify. Most estimates assume that they affect about 1% of all births. There are about 40,000 infants born in the United States each year that are affected by congenital heart disease. So congenital heart disease is more common than autism, 25 times more common than cystic fibrosis. When we talk about risk factors with patients when we're doing preconception counseling, we know that prematurity is a risk factor for heart disease, as well as family history, genetic syndromes, maternal diseases, assisted reproductive technology, and infection. This is a multi-billion-dollar industry associated with tremendous morbidity and mortality for patients, families, and a lot of stressors that hopefully we could avoid. So when we talk about cardiac intervention, we're clearly not talking about all congenital heart disease. We're not talking about small VSDs that we identify because our ultrasound technology is so phenomenal now that will close before the baby's ever born. We're talking about critical congenital heart disease. That is defined as those types of heart defects that require surgery or catheter-based intervention in the first year of life. These are the babies that have to have significant coordination of their delivery. They're often born with shock, cyanosis, tachypnea, and require a massive resuscitation in the delivery room and immediately after delivery. So when we talk more specifically about critical congenital heart disease, this can affect any area of the heart, but in general, we divide these up into left-sided obstructive lesions, right-sided obstructive lesions, parallel circulation, and then other, which is sort of our more rare, more complex type of defects. So I always put this slide up, and when I'm in person, I always see sort of groans from residents and fellows because this picture has been with us since medical school and is never going to go away. So the most important thing to think about this, I'm not going to go into significant detail about it, is that in utero, there are two right to left shunts that occur in the fetus because of high pulmonary vascular resistance and low systemic pressure. So we have the foramen ovale that shunts blood from the right to the left atrium, and the ductus arteriosus that shunts blood from the pulmonary artery to the aorta. This is sort of the crux of how critical congenital heart disease causes these babies to decompensate immediately at the time of birth. So with those physiologic changes of birth that happen immediately when a baby is born, you transition from placental gas exchange to pulmonary ventilation. You get this sudden drop in pulmonary vascular resistance when you take away the placenta that has normally been the lowest resistance site of blood flow, and you have a marked increase in pulmonary blood flow. Very quickly after delivery, this leads to a transition from that right to left shunting to a left to right shunting. When we talk about fetal interventions, this is not new technology. It's something that's become kind of a hot topic that's discussed at SMFM and fetal therapy meetings, but it's really not new. In 1987, there was fetal pacing for arrhythmia and hydrops, and then in 1991, Lindsay Allen pioneered fetal cardiac intervention by dilating the aortic valve. That attempt was successful, and the fetus went on to have a biventricular repair. But to date, even though we've been doing these cases for 30 years now, there is a lack of large bodies of evidence to base the use of fetal cardiac intervention. So why do we do it? What's our rationale for this cardiac intervention? The goal is to improve the survival for the fetuses at highest risk for prenatal or neonatal death. Our hope is that we can modify the course of cardiac growth and function and development in utero such that we can decrease that major lifelong morbidity. We hope to allow the fetus to remain in utero and remodel in that in utero environment with enhanced wound healing and capacity for myocyte proliferation. So what are the risks of these procedures? When I talk to patients in the office, the risks for mom are minimal. These are needle-based ultrasound-guided procedures that certainly have the risk for PPROM, preterm delivery, bleeding and infection, things that we talk to patients about all needle-based procedures. But the biggest risks of these procedures are for the fetus. So the fetus can have arrhythmia at the time of the procedure. You can develop hemopericardium, hemothorax. You can have a thrombus form. You can have your stent embolize. And ultimately, you can also have fetal death, which affects about 10% of fetal cardiac intervention cases. So our program here is the hallmark of the Congenital Cardiac Collaborative. The Congenital Cardiac Collaborative is a joint venture between Rainbow Children's Hospital, which is in Cleveland, Nationwide Children's Hospital in Columbus, Ohio, which is about 2 hours down the road, and then University Hospitals Harrington Heart Center and McDonald Women's Hospital, which is where I work. We are a very large multidisciplinary team involving MFM, pediatric cardiology from both of the two institutions, pediatric interventional cardiology from both institutions, maternal and fetal anesthesia from my institution, neonatology, palliative care, pediatric CT surgery, PICU, and genetics. These cases are performed at Rainbow Children's Hospital in the pediatric cath lab. All the cases are performed in Cleveland, so our Columbus comrades come up to do these cases with us. So if we go back to this that we talked about before, I'm going to look at a couple of specific types of cardiac pathology and how we intervene on those. First, we're going to talk about HLHS and a specific type of HLHS called aortic stenosis, particularly with mitral regurgitation. We're going to talk about pulmonary atresia with an intact septum, and we're also going to talk about pulmonary stenosis. So when we talk about hypoplastic left heart syndrome, it's important to know that it's very rare. It's only 2 to 3% of all of those congenital heart defects that we talked about to begin with. There is a very high mortality with HLHS, and the 5-year survival is only 65% even after repair. So despite the low incidence of HLHS, it is responsible for 25 to 40% of all neonatal cardiac deaths. So HLHS is kind of a catch-all term that involves all left-sided hypoplastic lesions. So it's a spectrum of disease with normally related great arteries. So you can have atresia or stenosis of the mitral valve, the aortic valve, or both, or a combination of thereof. So when we talk about severe aortic stenosis, think about you have an obstruction of your aortic valve coming off of the left ventricle. This increases that left ventricular pressure, so you get ventricular hypertrophy, a thickening of the muscle of the left ventricle to try to overcome that stenotic valve. This ultimately leads to systolic and diastolic dysfunction. So kind of looking at a schematic on the left, in picture A, you see a stenotic aortic valve, and you see overall normal structure of the heart at this point. So you get dilation, post-stenosis, and you can see kind of an enlarged aorta. So in your 3-vessel view, when you do your anatomy scan, sometimes your initial indication that there's a problem with the aortic valve will be an enlarged aorta in your 3-vessel view. Ultimately, this leads to that thickened, enlarged, abnormal left ventricle and endocardial fibroelastosis. So the increased pressure in the left ventricle causes damage to the muscular wall. So just our initial kind of first set of pictures. When we talk about the systolic and diastolic dysfunction, you can see in this first image, you can see a very echo bright, small, poorly contractile left ventricle that's caused by aortic stenosis. This was a twin case that was referred to us very early in our program that would have been a fantastic candidate for an aortic valvuloplasty, but could not be offered because of a twin gestation. And then in this second picture, you can see progressive decreased filling of that left ventricle and progressive hypoplasia leading to HLHS. So if we go even further, you have this systolic and diastolic dysfunction. You get severe mitral regurgitation, which ultimately backflows into your left atrium. So you get left atrial and left ventricular dilation, which ultimately compresses the RV and leads to decreased cardiac output. This is the reason for in utero demise in these patients. So if I start with the first image here, you can see very poor contractility of the left ventricle. Look at our second picture, we can see our significant mitral regurgitation. So this red jet that you see should not be here. That's not normal flow. And then when you get to your third picture, as this progressed in this pregnancy, you start to see pleural effusions, ascites, and you're ultimately seeing the end stages of heart failure in this baby. This baby was ultimately delivered and did not survive. So going back to our rationale for cardiac intervention for impending HLHS, the hope is that we can restore normal blood flow and promote growth of the left ventricle. Reduction in ventricular pressure enables more normal development and minimizes that secondary damage. Coronary blood flow in critical AS relies on retrograde flow from the arterial duct, which is poorly oxygenated, and further leads to increased damage in the heart. Increased diastolic pressures in the left ventricle impede forward flow in that coronary circulation. Sort of the biggest take-home point to know here is biventricular circulation, or 1.5 ventricular circulation, is much, much better in long-term outcomes and quality of life than univentricular circulation. So the question we ask ourselves for every case we're going to do is there a possibility we can turn this baby into a bi-V repair instead of a single ventricle repair? And then finally, high drops plus poor left ventricular function leads to an increased risk of fetal demise and an even higher increased risk of very quick neonatal demise. So cardiac intervention for impending HLHS. Our benefits. So we know that the 5-year survival, even with 3-stage successful surgical repair for these babies, is only about 65%. Even past that, the babies that survive, there's significant morbidity and mortality in the second decade of life and beyond. And often these patients that get into their 20s need a transplant. The hope is that we can create a bi-V or 1.5V repair. What are the drawbacks, the things that are hard about talking to patients about this? Most of these fetuses with severe valvular obstruction will survive to term. This is not a life-saving procedure. These are babies that are going to require lifelong cardiac care, maybe with catheter-based procedures, maybe with surgery. This is not curative, and we can ultimately lead to a preterm delivery, which worsens outcomes in babies with congenital heart disease and fetal death. So for intervention technique, at our center and most centers in the country, these are minimally invasive needle-based procedures. There are places that are doing a laparotomy in order to scan directly on the uterus to do these procedures. I have found, at least in an animal lab, I don't think they provide any benefit. I think we as maternal fetal medicine specialists are skilled at ultrasound and ultimately can do these procedures without that additional risk for mom. We give regional maternal anesthesia and then local fetal anesthesia to keep the fetus in the correct position. So this is just sort of a schematic of what the procedure looks like. We have the fetus inside the uterus, ultrasound guidance, which is actually provided by my pediatric cardiologist, and then a needle-based procedure through the maternal abdomen into the uterus, into the fetal chest. So for aortic stenosis, the goal is to put the needle directly through the apex of the heart through the left ventricle. You want an apex-forming left ventricle. I terminate the needle just inferior to the aortic valve, and a wire and a balloon are floated across the aortic valve. Just for scale, this is the size of balloon we're talking about. So this is a wire that kind of goes across the valve, and then this is a balloon that's dilated up to about 4 to 6 millimeters, depending on what, 4 to 6 millimeters, depending on what size of balloon we're using. So just to recap, critical AS leads to HLHS, which is left ventricular myocardial injury, altered coronary perfusion, and elevated subendocardial wall stress. So ultimately, there's a loss of pressure generating capability. When we talk about selection criteria for aortic valvuloplasty, not all AS cases are candidates for intervention. Like I said before, the goal is to have a biventricular repair. If you have a left ventricle that has no function, there's no benefit to doing aortic valvuloplasty. So what we're looking for when patients come into us is a large left ventricle with a persistent patency of the aortic valve. It can be a very small patency. Because of the increased pressure of the left ventricle, if you have your needle in the correct position, the wire is going to preferentially go across the aortic valve. You need to have a normal appearing mitral valve, reverse flow in the transverse arch, and left to right shunting at the atrial level. Additionally, kind of getting more into the nitty gritty of what we're looking for, you want left ventricular function that is qualitatively depressed, but still some existing left ventricular function. You need retrograde or bidirectional flow in the transverse arch, and then 2 of the following criteria. So monophasic mitral valve inflow, left to right flow across the atrial septum or an intact septum, and bidirectional flow in your pulmonary veins. So this is just a schematic of what a fetus with hypoplastic left heart with an open foramen versus a fetus with hypoplastic left heart with an intact septum look like. Ultimately, you should have minimal blood flow to your lungs in the in utero environment. When we allow this increase in pulmonary blood flow because of an intact septum, we lead to pressure-related damage in the lungs, and that's that nutmeg lung that we talk about. So these are sort of some MRI images and also ultrasound images of these kind of vacuoles in the lungs are not normal appearing fetal lungs. And what I often tell patients is the only thing worse than having a baby with hypoplastic left heart is having a hypoplast with bad lungs. So these are the babies that don't survive. So our candidates for intervention are candidates who have unequivocal AS, not aortic atresia. Like I said, we have to be able to get across the valve. Our LV long axis Z-score greater than or equal to -2, and a threshold score of greater than 4 of each of the following. These are just a summation of a left ventricle that is large enough that we think it can continue to develop and ultimately still has pressure generating capability. A question I get asked a lot from referring providers and also people at conferences is, what candidates do we exclude based on maternal characteristics? So in order to do these cases, you have to have good image quality. We do not have a BMI cutoff at our institution because I think, as we all know, sometimes you scan a patient with a BMI of 38 that scans beautifully, and sometimes you scan a patient with a BMI of 22 that scans awful. So it all depends on the individual patient and her sort of acoustic properties when you look. There needs to be minimal risk factors for premature delivery. Patients who have a history of a prior preterm delivery or have a history of a short cervix, oftentimes these procedures are not beneficial to them because it leads to an even more premature delivery than would have been anticipated. They need to have a lack of maternal medical comorbidities or infection. And then aneuploidy is definitely a topic of conversation. At our institution, we require some sort of aneuploidy screening prior to offering these procedures, but we do allow that to be non-invasive prenatal screening. So if patients have an NIPS, we will move forward from there. We have only had one patient get referred that had a fetus that had aneuploidy. The baby had Turner syndrome. We did offer intervention for that baby, but the parents ultimately decided to pursue pregnancy termination. So I'm going to go through just a couple of specific cases. The case that Ruchira was referring to is actually this case. It was the very first case that was done at our institution. So this was a 26-year-old gravidiform pair 3 at 29 and 1 who initially presented to us because she had an outside scan for size greater than dates at 28 weeks. She had had a normal community anatomic scan, had never been seen by MFM, had this growth scan at 28 weeks that showed size greater than dates. And the reason that she was size greater than dates is because she had poly. She was immediately referred for an MFM scan and had HLHS due to aortic stenosis and high drops. She had a fetal echo the same day that showed aortic stenosis with depressed left ventricular function, retrograde flow in the transverse arch, bulging atrial septum, and bidirectional flow in the pulmonary veins. This baby was also had early signs of hydrops when she was referred to us, had fairly significant ascites, and was admitted from our ultrasound unit for steroids prior to procedure. So I only have still images from her OB images for this one. So this was the initial view of her LVOT. So just to kind of orient yourself. So this is our large dilated left ventricle. We see this very bright kind of echo texture around here. This is damaged cardiac muscle. This is that EFE that we're talking about, and a small outflow coming off of the LVOT. So an additional kind of view of the 4-chamber heart, you can clearly see this is not a normal 4-chamber that you would see at 29 weeks. So pre-procedure LV function, you can see this dilated, boggy, abnormal appearing left ventricle, but you do see some contractility. You can see that there is function existing there, and you can kind of see the needle coming through the placenta here. We go forward to the next image. So this is your aortic valve right in here, and you can see just a very small wisp of flow going across this aortic valve. So that told us this aortic valve was patent. We see flow post the valve and know that we're able to get a wire across. So for the intervention, needles entering from the left side of the screen through the placenta in through the fetal chest wall and terminates just inferior to the aortic valve. You can see the bright tip of the needle here. And then in your subsequent image, you can see a wire floating across the aortic valve going across through here. You'll notice the image quality decreases when the needle is in there. That's caused by scatter from the needle. It's also caused by the fact that we give intracardiac epi immediately when the needle goes into the left ventricle. So we get a couple of bubbles in the heart, but multiple studies have shown improved cardiac outcomes with a small dose of epi. And then in this image, you can see the balloon dilating across the aortic valve. So we typically advance a little past the aortic valve and dilate sequentially, pulling back to dilate the valve multiple times. So post-procedure, immediately in the OR, you can clearly see your aortic valve is more open. So in a black and white image here, you can see an opening and a little bit of dilation at the level of the aortic valve. But the difference is even more profound in a color image. You can clearly see more color flow going across your aortic valve. Immediately pre-procedure, pulmonary vein Dopplers were in this 2-fro pattern, so leading to damage to the lungs. And immediately post-procedure, we see a much more normal appearing pulmonary vein Doppler. This patient ultimately went on to have an induced vaginal delivery at term, underwent a stage 1 repair with the hopes of converting to a bi-V circulation after that, but died of sepsis at 1 month of age that was really very much unexplained. But on autopsy, this baby appeared to have an aortic valve that had been dilated a bit. So our second case was a 34-year-old gravida 3 para 2002 at 24 weeks who had a fetal intervention. This case I mentioned to all of our fellows. So this is a patient who came in for an anatomy scan at 20 weeks. The heart was apex down. Overall, the images really looked fine, and it would have been very easy to say, the heart could be cleared, you could send the patient home. But there was a senior sonographer who did this image who said, something's just not right. I don't think this is normal. So the patient was brought back in a week to reassess, and there was a discrepancy between the right and left ventricle. She had a fetal echo that showed mild aortic stenosis at that time, so she's 21.5 weeks or so. Came back 1 week later and had severe AS with evolving HLHS. She had depressed LV function, severe MR, retrograde flow in the transverse arch, and again, a bulging atrial septum from left to right. So here was the image at 20 weeks that raised concern for the sonographer. I must have looked at this image now hundreds of times, and I still think on a day-to-day basis, I would probably look at this image and consider this normal. 22 weeks, you see just a little bit more of a discrepancy between the size of the left and right ventricle. And you can see in your LVOT, there's not the opening. You can't kind of clear out the valve and the outflow tract the way you expect to be able to clear it out. Aortic valve at 22 weeks measured 0.4 centimeters. So normal would be almost double that size at this point. And then at 22 weeks, you see this discrepancy between your aorta and your pulmonary valve. See that post-stenotic dilation, your aortic valve is a little bit larger than your pulmonary valve. And then here's your MR, this bright blue flow that's here. 22 weeks, 23 weeks, a week after this presentation, the aortic valve is even smaller. So instead of getting larger, it's getting smaller. And then your 3-vessel view is an even more demonstrable difference between the size of the aortic valve and the aorta and the pulmonary. So the imaging for this patient, you can see the needle's kind of coming in from the opposite side, and here's your balloon that's going across the aortic valve. So this was sequentially dilated again. And ultimately at 32 weeks, this baby had a near normal obstetric and fetal echo, obstetric ultrasound and fetal echo. She had complete antegrade flow in the transverse arch and had an LVOT that opens up and looks completely normal. So this patient was delivered at term via repeat cesarean delivery, and this baby was discharged home with mom on day of life 5. He ultimately had a repeat aortic valvuloplasty at 21 days of age, and today he is a little over 4 and hasn't had any major cardiac surgery, and hasn't been back to the cath lab since the time of this first dilation. His postnatal echo, you can see you get some aortic regurgitation from where we had done the dilation, but overall a widely patent aorta. And this baby here is Lorenzo. So this family follows up with us a lot and have since moved out of state and still come back to us for their cardiac care. Just to kind of briefly talk about an even more severe type of cardiac pathology, we also do fetal cardiac intervention for HLHS with an intact septum. So this is kind of the worst of the worst, the doom and gloom diagnosis that patients get. The mortality is the highest in this group. It's quoted in the literature with rates of 48 to 80% mortality. Our cardiologists here quote a mortality of about 50 to 60% within the first 30 days of life with this type of pathology. An intact atrial septum is only seen in 6% of patients with HLHS. So while to me it seems like a common diagnosis because it comes across my desk a lot, it's really not something that's seen very often. A lot of the mortality happens in the first week of life, and these are very hard cases for patients to go through. These are babies that are blue, go straight to the cath lab or to the OR, have an open chest, and often these patients never get to hold their babies at all. So this suggests that the mortality risk may be associated with intrapulmonary arterial damages during fetal development. So going back to the original schematic that we looked at before, we're getting in utero pulmonary blood flow, which causes damage to the lungs. Then we get massive pulmonary blood flow when the baby's born. So a schematic of what the stent looks like. So this is your atrial septum separating the right and left atrium. The goal is to put the stent directly in the middle in order to have adequate flow across. This is a much more technically complicated procedure that has significantly higher risks of morbidity and mortality for the baby. So case number 3, a 30-year-old gravida 2 pair 1 at 34 weeks who presented as an out-of-state transfer for fetal hydrops. This baby had aortic stenosis with a severely enlarged left ventricle with very depressed function. We didn't think that this left ventricle was a ventricle that could be saved. So this patient was taken to the OR in the setting of hydrops, and this patient did not have the image quality of some of our prior patients. But if you see this sort of little wispy flow across here, this is a very flimsy, bulging atrial septum that was completely intact. You can see the needle going across the atrial septum in these images and in the subsequent images. So this is a stent that is across. And one of the problems that we often come up with is when you have this very large dilated atrium, you often have very little room for error in order to ensure that your stent goes all the way across. So in this one, you can see it's almost like it's hanging on the edge of the septum. So this septum pushed across with the valve and with the stent and the needle. So it was kind of difficult to traverse across through there. But we did ultimately have a good outcome in the OR. We can see clear flow across the stent, which we didn't see any before. Unfortunately, this patient ruptured membranes 3 days post-procedure and had a repeat C-section. This baby went directly from delivery room to cath lab, and they were able to float a balloon across the existing stent that we had already placed and have additional atrial decompression. This baby underwent a successful stage 1 repair, but had renal failure in the post-operative period, and ultimately the parents withdrew care at about 3 weeks of life. Case number 4 is a 22-year-old gravida 1 pair 0 at 29 weeks who presented for fetal intervention. This is a patient that I followed from about 12 weeks. She was referred for a thickened NT initially. Her final diagnosis was a double outlet right ventricle with mitral atresia and a hypoplastic left ventricle. She had severe AS and an interrupted aortic arch with an intact septum. So this is a preoperative picture of the atrial septum, and I put this in here just so people can see the difference of the scope of what the atrial septum can look like. So this was a very thick, almost immobile atrial septum. so which also presents its own challenges in putting a stent across. So these are some operative pictures, and one of the things that I want to point out is sort of things that you figure out when you do these cases and kind of troubleshooting on the day of. You can see here a stent that is parallel to the atrial septum. So the initial stent that was placed actually turned in the atrial septum because the septum was so thick. So we got all the way across and it kind of turned almost in the middle of the septum, and we were seeing no flow. The baby tolerated the procedure fine, so we ultimately went in again and placed a second stent. So you can see in this final picture, here's the first stent, here's the needle coming in for the second stent that's being dilated, and ultimately one stent, two stents for this baby. So post-intervention, pre-procedure pulmonary vein Dopplers were this complete two-fro pattern, and post-procedure we were starting to see a little bit of improvement in the pulmonary vein Dopplers. This patient ultimately underwent a primary cesarean section at 35 weeks for worsening fetal hydrops. She had an open atrial septectomy on bypass on day of life 1 and had a demise on day of life 2 despite a successful cardiac intervention. Case number 5 is a 38-year-old gravida 5 para 3013 at 28 weeks presenting for fetal intervention. This patient had an increased NT and had an early fetal echo with concern for HLHS. She was ultimately diagnosed with AAMR with a highly restricted atrial septum with two-fro flow in the pulmonary veins. So pre-procedure, you can see this retrograde flow in the aortic arch, and you can see a very small left ventricle with no flow at all. And then the intervention for this case, you can see a needle coming across going into our atrial septum. And then post-procedure, here was a stent that was kind of ideally placed. Your septum is right here across the middle. And then you can see clear flow going across on both sides. So this baby, post-procedure, had pulmonary venous forward to reverse VTI ratio that improved from 1:1 to 3:1. This baby was delivered vaginally at term and transferred to the cath lab for additional atrial septal decompression. He ultimately had a stage 1 repair and is now 4 years of age and undergoing a transplant evaluation. The things that we learn as these cases go on, sometimes there's underlying pathology that we are unaware of. This baby has had pulmonaries that never grew. He's had multiple procedures, multiple stents placed in his pulmonaries. So ultimately is now on the transplant list for a heart lung. And then finally, just really quickly, I'm going to talk about PA-IVS cases. So the use of cardiac intervention for pulmonary atresia with an intact ventricular septum is controversial. Some people feel like outcomes from PA-IVS are pretty good and it's not worth the risk of a cardiac intervention. But ultimately, the thing that is hard to predict is the babies that are not going to do well with PA-IVS and those that are going to go down that single ventricle pathway. So this first case was a 32-year-old gravida 4 para 1021 at 23 weeks who traveled to us from Dubai for fetal cardiac intervention. She was a dentist who actually was moving to Toronto at the time of this evaluation. So when we initially saw her, there was no antegrade flow across the pulmonary valve. She had tricuspid regurgitation that suggested that the right ventricle could still generate significant pressure, and the tricuspid valve Z-score was minus 2.19. The RV was tripartite with no sinusoids, which are important in these cases. So pre-procedure, you can see clearly pulmonary atresia. In this case, you can see no flow across your pulmonary valve and flow reversal in the ductus. So this is the procedural case. So you can see your needle coming in here, and ultimately the area that you're aiming for is in here. So this is a 22 gauge needle that was initially placed to determine trajectory, and then ultimately an 18 gauge trocar was used to do the actual procedure. So you see needle enter and approach where the pulmonary valve is stenotic or atretic. And then the stylet is removed, so blood flow is confirmed to determine you're in the right place. And then ultimately a wire is floated across the valve and sequentially dilated. So this patient ultimately went back to Dubai and had a catheter-based valvuloplasty on day of life 1, and this baby is almost 3 now and has had no significant cardiac events since that time. Just a brief review of the data. The largest data set that's ever been published, this was, the principal author of this was out of Boston. So for fetal aortic valvuloplasty, they evaluated 176 patients for an aortic valvuloplasty, and the most important part of this schematic is over on the right. They had 87 cases that they offered an aortic valvuloplasty to. Of those, 70 out of 86 were successful and 16 were not. Of the 70 that were successful, there were 9 peri-procedural demises, 1 late IUFD, and 4 terminations of pregnancy. When we look down here on the bottom, patients who did not receive an aortic valvuloplasty, the likelihood of them being discharged as a biventricular repair is very small. So of the 23 who were live born, only 5 were discharged as a biventricular repair. Over here, patients who had a successful aortic valvuloplasty, so 56 were live born and 24 of those were discharged as a biventricular repair, which is your ultimate goal. And then when we look at our restrictive or intact septum patients, so 49 were evaluated, 37 were offered stent placement or a septostomy. Of those, 24 were successful, 12 were not successful. So going back to increasing technical difficulty, less of these procedures are successful. Of the 24 that were successful, 2 had a peri-procedural demise. So of the 22 who were live born, 14 of the ones who had a successful decompression of the atrial septum survived to discharge, and the ones that did not, only 4 survived to discharge. So it's a significant difference. So our experience with the Congenital Heart Collaborative since July of 2018, we've had a total of 38 patients referred in. 19 of those patients were brought to Cleveland, and of those 19 patients, 16 were offered intervention, 2 elected for termination, and 14 maternal fetal pairs were offered the procedure, and a total of 18 procedures were performed. So for overall outcomes for our critical AS cases, 7 procedures were performed with 1 procedure-related demise. We had 2 single ventricle palliation cases, 2 biventricular repairs, and 1 1.5 V repair. For our restrictive septum cases, we had 4 procedures, 1 procedure-related demise, 1 that is a stage 1 awaiting transplant, 1 that is status post-Glenn and alive and well, and 1 that had a death after a hybrid. For PAIVS cases, we've done 3 cases, all have had term deliveries, all are alive and well with biventricular function and only catheter-based interventions. So if we step into the future, what is next for us? So these images are images from our sheep lab. So this is a fetal sheep that ultimately had a stent placed in the pulmonary valve with the thought of, can we replace the pulmonary valve? So this is a stent that has a tissue engineered valve that is sewn into it. And you can clearly see flow going across this stent and this valve that we have put in here. So this is a covered stent that has this tissue engineered valve that's sewn into it. And the thought is that ultimately this could be a treatment for cases of tetralogy of Fallot with an absent pulmonary, cases that have a very poor outcome, that perhaps we could place these in utero and allow these babies to develop their own native pulmonary valve while they're in utero. So this is the mom and this is Herbie. This is this little fetal sheep that we placed this valve in. He ultimately was survived for over a year and had completely normal function of his pulmonary valve that had grown into this stent that we had placed. So in conclusion, the progression of fetal heart disease is rapid in cases of aortic stenosis. If there's any concern, these are patients that need to be seen weekly to see the progression to determine if these are patients that are appropriate for a referral for cardiac intervention. A number of babies will die in the newborn period despite good surgical repair because of the secondary pulmonary damage and myocardial disease that's caused by these types of severe cardiac pathology. Fetal intervention seems to be encouraging in certain cases, and if it's performed, it's more likely to be successful earlier prior to that significant damage rather than later in gestation. A multidisciplinary team approach is essential to the success of an interventional fetal cardiac program with the welfare of the mother paramount. Development of smaller specialized equipment will help in the performance of these procedures earlier in pregnancy with minimal bleeding complications, but patient selection can only be rationalized by multi-center experiences to establish an intention to treat database. So the IFCIR database is trying to put this data together for us to help us determine which cases are most successful with some of the most high volume centers in the world. And these are just kind of some operative pictures from what these cases look like for us. So These are cath tables that are set up over here. So these are two pediatric interventional cardiologists, one from my institution and one from Nationwide, who kind of set everything up for us. We have extensive fetal medications that are used, and this is kind of our balloon deployment system. These are two pediatric cardiologists, one from each institution, that scan for me, and then this is me here doing these cases. All right, does anybody have any questions? I managed to get through that pretty quickly.
Thank you, Dr. Ragsdale. Thank you for that excellent presentation.
No problem.
Are there any questions?
Hello, can you hear me?
I can.
Yes, we do.
I'm Haley Sweat-Patrick. I'm one of the MFMs here. Thank you so much for such a really interesting talk. I guess I'm curious, that case that really jumped out at me was the one where I agree. I think if I had looked at that image, I would have called it normal, and that baby seemed to have one of the best outcomes. So I guess, do you have tips for us and our sonographers to pick up these subtle cases early and, find babies before they get to that, high drops at 28 weeks?
I think the take home and what I say to all of our fellows is, the one thing when you come out of fellowship, and even I'm now almost 10 years out of fellowship, the thing that I think we continue to learn every day is by ultrasound. And I think ultrasound is a hand-in-hand relationship with sonographers. And ultimately, they do much more hands-on scanning than we do and see a lot of things. And I think the intuition of my sonographer saved that baby. She was the one who said, I think something's wrong. And that partnership and that professional relationship between us and our sonographers, even if we think it's normal bringing patients back, if we bring 15 patients back and in one case they're right and there is something that's wrong, it's worth that bringing them back. So I think that's what I have learned from the process. But like I said, still to this day, I look at that picture and I would call it normal. But she looked at it and didn't think it was normal.
Thank you so much for that. And thank you again for your talk.
No problem.
Also, Ellie, like there was an evolution in that. Yeah, like we went on to see a more hypoplastic looking aorta later on. So there was an evolution. So I think your point is important in terms of, like, if you think something is not right, just bring the patient back and maybe see them a couple times. Have you seen any significant arrhythmias post-procedure in these patients, and if they are transient or just.
So we have, at the time of all of these procedures, I have fetal rescue meds. So I have atropine, epinephrine, and then we have debated keeping antiarrhythmics on the table. We have not actually done that in the past. I had one case of SVT that ultimately spontaneously resolved, which was sort of unexplained. The person in our team who has the most extensive experience, Amy Armstrong, is a pediatric interventional cardiologist who came to Nationwide from Michigan. She's actually the person who initiated this program that was done here. So she has done about 70 or 80 cases total in her career. And she said there's no real rhyme or reason to the babies that do develop an arrhythmia. Ultimately, they think that you probably hit the electroconductive system somewhere in the heart when your needle goes in, and it's just an unpredicted complication of the procedure. But ultimately, luckily, we haven't had a significant issue with that. The biggest procedure-related issue, in about 50% of the cases that we do, I drain a pericardial effusion, a hemopericardium. We almost always see that, and we start to get that tamponade effect, which increases your risk of getting an arrhythmia. So I often do, I'm right-handed, so I do the dilation with my right hand, and I often have another needle in my left hand, and I drain very quickly from my left hand to be able to take that tamponade effect away.
That's amazing. And then just a question for more of learners. If fellows want to follow your career path, how did you get involved in this collaborative and
so I think so it's very interesting. I think you can change the course and the trajectory of your career at a lot of different stages. I know Jane Gerda sent me a text this morning. Jane was a resident when I was a fellow at Einstein, and I was definitely a maternalist as a fellow. I was really somebody who thought I was going to take care of the sickest moms. I had very little interest in fetal, but I was lucky enough to train at an institution that did a lot of needle work. So when I started in this job here, Honor Wolf, who you'll remember, said to me, "You're not a maternal person, you're a fetal person." And I said, "No, there's no way. I'm not a fetal person." But I took her advice and guidance and mentorship and sort of started this program. And I just happened to be in the right place at the right time when this program was being developed and started, and was an MFM who had needle skills at baseline and was able to sort of learn this process. So I think you have to be open to your career taking different directions than you expected.
You, Ellie. And yes, I cannot forget Dr. Wolf. Her words ring in my ear a lot of times in any critical condition. Let's see. Another question that came to my mind was that in hypoplastic left heart cases, are you offering procedure only in the case where there is critical aortic stenosis? Or is it because if you see hypoplastic aorta, would you consider balloon dilation, or is it only in cases of valvular issues?
Only in cases of valvular issues. It's not been shown to be effective in patients who have an interrupted arch, like those types of cases where it's just not been shown to be effective. You don't get that same continued growth as you go forward. Even with a coarct, people have tried to dilate coarcts and you just don't get the same growth of the aorta afterwards. And those are patients who also have a more successful postnatal surgical repair. So the risks of in utero procedure are not worth it for those patients, because they're often going to have a biventricular repair anyway.
Often, let's see if give other.
All right, are there any other questions? Dr. Sharma, you were kind of breaking up with that last statement you made, but I think you said you wanted me to open it up to other questions.
Dr. Ragsdale, this is Jean Gerda. Thank you for a great talk. That was one of my questions, is how does an MFM fellow get involved with these procedures? And I guess it very much depends on where you train. My second question was how many of these congenital heart programs are available in the country? It's such an extensive team. How common are these programs around the country?
So in the last time that it was a summary was published, so in 2020, the highest volume center in the country was Boston Children's. The second highest volume center was Texas Children's. Other than that, and there's us in Michigan are kind of the two who follow behind there. And then there are several, maybe 4 to 5 other sites in the country that do 1 or 2 a year. But there are only the 4 sites in the country that do 6 or more in a year. But there are a total of about 12 places in the United States that do these cases. Columbia has done a few, which is probably the closest to you guys, but Boston Children's is still the mecca of these cases. But we're
That's
always
incredible. Yeah,
it's a very
unique.
small community, and there are a lot of conversations that exists, and we share images back and forth. We send images to Boston, they send images to us, and we have a lot of collaborative discussions about, would it be beneficial in this case? Should we move forward from there?
I see that Dr. Rosenfeld has her hand up.
Good morning. I'm one of the MFM fellows. Thank you so much for a really eye-opening talk. And I'm really excited that some of these options be available to our patients. What are some of the patients that we should think about offering a referral to you?
So I think so we review virtually a lot of cases that are not candidates for intervention. So any case of HLHS that you feel like has the potential to have aortic stenosis, or a case that has an intact septum, we are happy to remotely review images for your patients and talk to you about it and determine if it's a case that would be worth us looking at. Boston feels the same way. We do a lot of these virtual referrals to kind of take a look at things. I think the most important thing is just keeping it on your radar that there is a possibility for intervention. We all practice in sort of different demographic locations and patients who have different thoughts. I'm in the Midwest in Cleveland, and patients who choose pregnancy interruption in the case of severe congenital heart disease are rare. So I kind of get to see the natural progression of these in patients who want everything done to have an option. So I think we also always have to offer patients the full gamut of options. I do that in every patient I see for cardiac intervention. I offer expectant management, pregnancy discontinuation versus an in utero procedure. But we're happy to look at anybody's images. And my goal is to bring as few patients to Cleveland that are not candidates for intervention as possible. We have some philanthropic funds that will pay for patients to come here to be evaluated, but the goal is not to bring patients here that don't have a chance to have cardiac intervention.
All right. Well, Dr. Ragsdale, thank you so much for this really eye-opening talk. We very much appreciate it.
Before I duck off, for the people who have known me for a long time, I refer to these, let's see if I can get this to move forward. Whoops. So I refer to this as my first and third year fellowship project. Jane, these are my two kids that were born when I was a fellow. So they're a little different now than the last time you saw them.
Amazing. Thank you, Ellie.
Thank you,
All right.
Ellie. Thank you so much.
Thank you, guys. Bye.
Bye-bye. All right. Thank you, everyone. I hope everyone has a productive and fulfilling day.